What's up, guys? It is November 5, 2025. I haven't recorded a video in a while, and quite frankly, it's because residency has been incredibly stressful. I mean, this has probably been the most stressful stretch of residency. Um, so especially my last block. I just finished 3 weeks in the clinic, and now I'm back on the wards in the hospital. And to be perfectly honest with you guys, what I did not expect in residency was for the clinic to be even more difficult than wards. You see, to be a good clinician, I mean, let me put it this way. What I've discovered in the past, month is that being a bad clinician is really easy. And unfortunately, in medical school, I saw examples of bad clinicians. Um, in that you can just basically refer out for any problem that's actually complex, prescribe pain medications for any sort of unexplained pain, um, and really put the bread and butter. I mean, put the like hard parts of internal medicine on the back burner. The differential diagnosis, the digging through charts, um, and things like that on the back burner. You can being a bad, clinician is easy. And the reason for that, and I'm generalizing here, it's really not that easy. I mean, if you're a bad enough clinician, you are going to be sued, but it's easier to be a bad clinician than to be a bad hospitalist. And the reason for that is that these patients, for the most part, are not acute. Okay. If they are acute, you should know when to send them to the hospital. But for the most part, they're not acute. They come in with these weird, I shouldn't say weird, but these complex, difficult to understand problems with a million different causes like back pain or chest pain or abdominal pain or things like that. And you have to work that up. But they're not acute. So for them, usually they're not acute. Um, and so you can be a bad clinician and get away with it. But here as an internal medicine resident, as somebody who staffs every one of my patients with an attending physician, it's not easy to be a bad clinician, and that's how it should be, right? Because I'm learning, because I'm trying to be the best doctor that I can be. But anyways, and so in a lot of ways, this has been helpful, albeit stressful. Um, but I'll give you one example of a really stressful presentation I had, which I'm still kicking myself for. And essentially, what happened, because I think this was one case where there, it was kind of a wake up call to me, to really be better and do better in clinic. So, and I won't get into the details of the case. I'll just give the kind of a broad overview. Basically, what happened was that there's this patient who has abdominal pain after he eats, right? So postprandial abdominal pain. Now, this patient also has chronic disease. And so when I presented this patient to my attending, I said, listen, this patient has a reason to be in chronic pain. And I think it's reasonable to increase his pain regimen, to opioids or whatever. He was already on opioids, but maybe to increase the frequency, and also get him in touch with like a palliative care or somebody who can help this patient more with the pain than we can. But then she was like, yes, it makes sense for this patient to have pain in the context of his diagnosis, but you're telling me that this pain is postprandial. Okay. And then she got into the fact, like, what are possible causes of postprandial pain? All right. So what I was suggesting was, okay, there's some sort of a cancer, right? The cancer is causing the postprandial pain. There's some sort of mass effect down there, but what else could be causing it? And I hadn't put that much thought into it because I thought I already knew the answer. I was, anchoring myself to what I thought I already knew instead of really using my brain and for this problem and really thinking of all the possible causes, the differential diagnosis, right? So anyway, she asked me, in the room, and I hadn't put any thought into it before. And basically I said, when I think about postprandial abdominal pain, the first thing that comes to my mind is peptic ulcer disease. She was like, that's right. And what kind of things can cause peptic ulcer disease? And I explained, it could be H. pylori, it could be NSAIDs, excessive NSAID use, like excessive ibuprofen use, things like that. But the patient doesn't use NSAIDs. Um, she was like, all right, so we got peptic ulcer disease. What else do we have on a differential? And I just couldn't think of anything else. On the spot, I couldn't think of what else can cause postprandial abdominal pain after eating. And as it turns out, this patient had risk factors, like abnormal lipids. And so she just kind of looked at me disappointed and said, how about mesenteric ischemia, right? Chronic mesenteric ischemia. And I was like, yes, yeah, I should have thought about that as well. Um, and so basically, and so, and the other thing is, I had anchored on this cancer is causing abdominal pain. What she did while I was presenting was really look back into the chart on Cerner. And she said, this patient's cancer is not, in a location or in a, it doesn't seem to be in a manner which can cause um, abdominal pain, postprandial abdominal pain. So it can't be the only explanation for this issue. Um, and so basically, she had some pretty harsh feedback for me. She was like, you know, you're behind your peers at this point, right? Because you need to be able to evaluate a patient and have a good differential diagnosis of what's causing their problem, right? Not just one or two things. And that's number one. Number two, you should be doing a thorough chart review on every patient. Um, and so, this attending that I staffed with is has a lot of power in the administration. So basically, I feel like I might have been red flagged, as that wasn't good, and she did write an evaluation for me too. So, that, you know, so, you know, now with that experience and also with me scoring below average on the ITE, like the internal medicine in training exam, they want to put me on some sort of like learning plan or something. We haven't talked too much about it. But it's incredibly stressful, right? Because, now I know that I'm on like some sort of how do I put it? I know that I'm on the hot seat, right? Not a reason to freak out too much, but I'm on their monitor, right? As somebody who seems to be underperforming. Um, and it's just, you know, I'll probably be okay, but my mind tends to always think about worst case scenarios. Like, what do I need to make sure I avoid? And the absolute number one worst case scenario for me would be this. I have worked so hard to get to this point in as a resident physician. Worst case scenario for me would be like falling behind, losing a year of my life, losing any time off, you know, for remediation. I don't want that. So I've really, really been trying to work as hard as I can for the past few weeks. Really trying to make a point of studying whenever I can, trying to improve my knowledge whenever I can. And it's led to an incredible amount of stress because I'm inevitably losing a lot of sleep over this. It's 11:50 p.m. right now, for example, and I have to wake up at 4:30 a.m. tomorrow. Um, so it's been a rough time. Uh, Talking about clinic a little bit more. Um, some like learning issues, some takeaways from my last clinic block. I'm on my second week of wards right now. I finished clinic a couple weeks ago, but um, some takeaways from my last clinic block. Like I said, chart review is really important, but it's a pain in the ass, man. And it's easier said than done. These things, like, of course, it's important, but when you have a packed schedule, um, then or when you're running behind, it's hard to do a thorough chart review. I mean, because a patient is sitting in that room over there, and they're going to be annoyed, if you're just sitting down and staring at their chart instead of going into the room, because they don't know that you're looking at the chart. For all they know, you're just ignoring them, making them sit for an hour. Now, it never lasts an hour, but that's what it feels like to them. Um, so there's this stress of trying to be efficient with chart review, and the electronic medical record we use here, Cerner. Uh, it's easy to read notes from other physicians in the same hospital, but it's a pain in the ass to read notes from physicians from other hospitals. Um, and then there's a lot of notes to get through. If you can either sort your note by physician, but then you can also sort notes by, if you're curious about what physical therapy is done for this patient, or what kind of messages have been sent back and forth for this patient. That's even more chart digging, right? Um, or in this patient's case, you know, this patient had cancer. I should have really done a good, thorough chart review on what is the pathology of the cancer, what is the distribution of the cancer. And because I was running behind, I didn't do that chart review. I just read the previous note, the one that referred him to us, which is indicating that the patient needs some extra, pain control for his cancer, and they're coming to the PCP for that. And then I said, all right, I'm going to roll with that. I was lazy. And I wasn't efficient. That's the main thing. I wasn't efficient because you can work hard, you can not be lazy, but still be inefficient, and it comes to the same result of not getting your work done. Um, so chart review is really important, and I think when my next clinic block comes up in January, what I'm going to try and do is, because for wards I start really really early, right? I get there at like 5 a.m. But for clinic, I've been a little bit more lazy. I've been doing some chart review the night before, but really, I've been getting there at 7:30 a.m. Which is when we have like a required 30-minute conference before the clinic day starts. I think what I'm going to try and do in my next clinic block is get there at like 6:30 a.m. to kind of have a good grasp of all my clinic patients before, getting the day started. Um, so there's that. And then, the other thing is, like I talked about, back pain, cough, abdominal pain, angina, substernal chest pain. All these things have very wide differentials that you really need to think about for every patient. And for a lot of them, if you know that they're coming in with that problem, then it's not that hard. You can go to UpToDate and look up, back pain in an adult, and you'll see, oh, it can be mechanical, like, I don't know, spondylolysis, osteoporosis, osteoarthritis. It can be malignant, it can be infectious, so on and so forth. Um, but then you might have, like, you'll be in a patient's clinic room and you don't know why the patient's here. Maybe it's a new patient. Maybe it just wasn't recorded well enough why the patient's coming with us. Maybe the patient, just didn't share this problem with anybody until the doctor comes in. And then the patient goes, oh, look, I also have knee pain. Oh, look, I also have dry mouth for the past few, months. Oh, look, I also have brittle fingernails, um, so on and so forth. I have this weird rash. You need to be well versed enough to have a good differential diagnosis for all these different conditions. What can be the different things that can be causing these? Because you don't always have the time to go look it up on open evidence, to look it up on UpToDate. Um, because the clinic is flowing, right? Now, to be fair, with this example I gave on the last patient, what I should have done instead of being lazy is I should have sat down on a computer really thought about it before going and staffing with my attending. Um, but a lot of times you don't have time to sit down like that, right? Because you're running behind. Um, so, anyways, that's just kind of like my learning issues from clinic. Just you have to be proactive in clinic as well. Um, and then some complaints about clinic. You know, there is a message center in clinic, which is just incredibly annoying because I just said I'm off clinic now. I'm in wards, but I'm still getting messages from my patients, and to refill certain medications, or if they got labs done, I'm getting their lab results back. So here I am trying to manage a list of hospital patients, and then I'm also getting messages from my clinic patients, and I just don't have the time to catch up. I got a very important lab value back from one of my clinic patients today, actually yesterday at like 9 p.m. And I really need to call that patient about this lab value, but I haven't had the chance because I'm so busy in the hospital. So tomorrow I'm gonna find some time to call this patient. But I just looked at my patient list for tomorrow, and there's 3 new admissions to our team, so I know I'm gonna be really busy. But I have to carve out some time to talk to this patient, to call this patient, this outpatient. So you're always on in clinic, and that's just the other annoying part of clinic. So clinic can be rewarding. I diagnosed some cool stuff, and the hours are still better than the wards. Even if you do come in a little bit earlier to chart review, but it's it is a huge learning curve, just like wards, to be a good clinician. Big learning curve. And so that's been clinic, and then you know so and that those events are like the main reason why I've been so stressed lately. Um, with wards though, because I've been on wards the past 2 weeks. I feel like I'm getting better. I'm still making stupid mistakes every single day, but I'm getting better. The mistakes are being more far apart. But like for example, today we had a patient who came to my team from the ICU. So the intensive care unit had admitted this patient for sepsis, and then the patient stepped down to my team. Um, so for further management, because the critical care portion of this patient's care was resolved. So I was really busy. I have 4 other patients, and so I was really trying to get things together for those 4 other patients. And when it came to time to review this patient, basically what I did is I took that note from the ICU, and the ICU writes their notes in a different format, but I reorganized that note in our format. And then I went to look through like the imaging and the labs and stuff, of course, as well, and the vital signs and all that stuff too. But to kind of organize the main problem list for my note, that's what I did. And as it turns out, the ICU people, maybe for good reason, had not really gone into the patient's health problems, because this patient is not from the hospital I work at originally. The patient had originally transferred from some other hospital. And anyway, so this patient has a bunch of other problems, that just were kind of ignored during this hospital stay, because the patient isn't on any medications for it, and it's just kind of on the back burner. But okay, it turns out this patient doesn't have a spleen. It turns out this patient has other problems which complicate the picture, and not just well, to some extent complicate, because you have to think about more things, but honestly, to a greater extent, clarify the picture, right, on what can be causing this patient's issues. Um, and so, what I should have done is I should have, instead of relying so much on the note that the NP wrote from the ICU, I should have basically gotten a brand new history from this patient, right? A full HPI, and I should have done a full physical exam. I still need to work on my physical exam skills, and it's just a matter. The biggest issue, man, is it's just time management. I'm always so rushed that, and the patients are always so. The patients don't necessarily want to move and stuff, that I don't always do like a full physical exam. So like for this patient, it would have been important for me to, I don't know, look at the to just to instead of just listening to the lungs and heart and pressing on the abdomen, which is basically the extent of my physical exam usually, unless there's other things which are obvious that I need to look at. Like, for example, if a patient has heart failure, then okay, I'll look for edema too and whatnot. But, anyways, instead of just doing those three main things, it's important to always do other things. So, like my attending physician I work with right now has a rule: for every new patient, you should always look at their feet. Um, and honestly, I mean, sometimes it's been a bit excessive, but there have been times where I'm like, I'm glad I looked at the patient's feet. So, you just got to be more thorough with the physical exam, and that's the thing. That's just the problem with Word is just trying to balance thoroughness with efficiency. Being in the because I was in the hospital for 14 hours. I left at 7 p.m. You know, so that's just what it is. And so there's that. And then when I come home, I'm just really, really trying to do what I can to brush up on my medical knowledge. So I've been trying to do UWorld questions. I'm doing Anki every day. And what I really should be doing is mix app questions. And I'll get to those when I'm done with UWorld and when I'm done with step three. Um, God knows when that's going to happen. I was originally planning for February, but I don't know if I'm going to get the time off to take it then. We'll see what happens. And I just I haven't had the time to do enough questions. Um, so, anyways, I'm really stressed, but there are good things to this too. I mean, because despite being really stressed, I will say, that I've been more I've been stressed, but my soul has also been more calm in the past few weeks. And I know that doesn't make any sense. So let me explain. Like when I felt like I had more free time, I was how do I was anxious about other aspects of my life besides my work. Um, you know, what does my future look like? Why am I doing this? I'm, at a certain age now where, I need to find, God willing, inshallah, I need to find like a wife and have kids someday. And when is that going to happen? Just all these thoughts ruminating in my head, but now that, within the past few weeks and really within the past couple of months, I've had these mishaps, I've had these mistakes, which have made me more anxious and really made me try to get my shit together and focus as much as I can on this career. Even though I'm stressed, even though my free time is significantly decreased, um, I'm not worrying about those things anymore. My mind is focused. I know what I need to do. I have a purpose, and the purpose is, at least for this year, for this first year of residency, I need to focus on being the best doctor I can be. I cannot focus on anything else. I can't think of anything else. And in fact, the fact that I'm, single right now, the fact that I'm living away from my parents right now, um, because because I lived with my parents throughout medical school, right? This is like the first time in my life I'm living away from my parents. Stuff like this, I don't feel as bad about it anymore because I know that I can't have any distractions right now. I really, really need to focus on making myself the best doctor I can be. Um, so there's positives to everything. You know, there there's a the Arab word is hayir. There's a hayir to everything. There's a goodness to everything, and I just thank God for these opportunities. Because I know it sounds cliche, but I mean honestly, at the end of the day, the things I'm worried about when there's people starving in the world, when there's people all kinds of things happening in the world, it's it's, I should I should thank God that I'm so lucky, right? Um, and it just it's I think it's important that despite that while I keep working hard and while I keep grinding, while I keep trying to elevate myself in this life, I also stay mindful of the fact that everything that happened to me is thanks to God ultimately, and of course thanks to a lot of other people too. But um, anyways, so I'll end with that positive note. I'm focused, I'm determined, and I believe in myself. But it's been a really stressful time. So, anyways, um, all right, I'll have a good one.